coming to this special seminar. Before we get started, I wanted to thank Patrick Sullivan, who's sitting back there, for donating our inflatable colon to our cancer center. And I would like to really thank him. We rolled it out for its debut at Family Weekend, and lots of people came by to visit. And it's amazing how many gastroenterologists came by who have kids who go to Brown University. But we had fun with it. So today it's very exciting to welcome Roy Herbst from Yale University, where he is the Ensign Professor of Medical Oncology and Professor of Pharmacology and Chief of Medical Oncology, who's been there. Well, you're also Associate Director for Translational Research and more recently Deputy Director. He's been there since 2011. It is such a pleasure to welcome Dr. Herbst, who is one of the premier physician scientists and clinician investigators, I guess, in the world. He's a role model, and I think we will all learn so much from him today. What else can I tell you? Well, his career path. So he started at Yale University with a bachelor's degree. Then he went to Cornell Rockefeller, where he earned his MD and PhD degrees, went to the Brigham and Dana-Farber for residency and fellowship, and then went to MD Anderson, where he was Chief of Thoracic Medical Oncology for a number of years until 2011, when he moved to New Haven. And he's been involved in like amazing clinical trials in lung cancer, all kinds of targeted agents and immunotherapy agents, and he even did some stuff with Trail way back when, and it's always great to hear from him. He was here earlier. This is the second lecture today. The first lecture was the Paul Calabresi lecture in honor of Paul Calabresi, who, I don't know how much you're going to say about Paul Calabresi at all, but just for our Cancer Center members, Paul Calabresi was chair of medicine here at Brown for about 20 years and directed a cancer center here in the 1980s and early 90s. And Roy has personal connections with the Calabresi family, which has made a lot of achievements, not just in medicine, but other walks of life. And I think it's important at a place like Brown that we remember Dr. Calabresi and know of his impact. He was a real giant in the field of oncology. And maybe Roy can say a couple of words about him just for our Cancer Center members to know a little bit more about him, because I think it would be fun. So we welcome you, Roy. Oh, and I would like to give you a small gift from our Cancer Center. We should probably do a quick, just
open it up and do a photo.
So in here is a gift from the Cancer Center, but there's also a manuscript for Roy to read on the train going back to New Haven.
Always an agenda.
Yeah. Here, let's get the audience.
You really know how to do this.
All right. Looking forward to your talk.
Well, thanks, Wafik. It's a pleasure to be here. I actually took out some of the pictures I showed this morning, but Paul Calabresi was a major figure here at Brown in the Cancer Center. Probably some of you know, Brown was one of the first NCI designated cancer centers. And, I think one was in the 80s and early 90s. Paul actually, worked with Joe Bertino and others in pharmacology, Arnold Welch at Yale, one of the developers of 5FU, which you know very well from the colorectal cancer world. I came here in 1968 to Brown. Brown did not had a new medical school back then, and really was involved in forming the whole medical school, and was a visionary leader. And he used his international prominence to bring people here to recruit. He was at a hospital, Roger Williams Hospital initially. That was his base, but then ultimately moved over to Rhode Island Hospital. But really, as we think about what we're talking about today, translational research, and I talked to some of you about this earlier, from the lab to the clinic is what really is the essence of what makes a cancer center, in my opinion. I bet Wafik would agree that we want to have impact and bring science from the lab to the clinic, and that's certainly the type of thing that Paul was always a champion of. I met Paul because life takes you on funny paths. So I was grew up in New Rochelle, New York, and my mother always wanted me to be a doctor. So then we get to Yale, and you get assigned to a room, and there's Peter Calabresi's Paul's son, and there's Paul. So my mother tells Paul, I want my son to be an oncologist. So it happened. But a few steps in between. But mentorship is important. And the other thing I'll leave you all with today, I just met with a wonderful group in the lab. Mentorship, and you work with people. They provide you guidance, both in terms of your research work. Your career is important, and then we all become mentors. And so Paul Calabresi was really the essence of that, and that's why. And I'm sure you're trying to get one of these. The K-12 award, the K award for oncology, is called the Calabresi Award. And we have one at Yale, and it took us a while to get it, but that funds for young investigators, instructor level and up, and it's important for retention and recruitment. And then it gives people time, a few years, to get a K08, which is, of course, the first step as you move on to our awards and other funded grants. So I'm really happy to be here today. Wafik is always the most generous and wonderful host. That was very kind of you, that introduction. And what I thought I'd do is just take you for a little tour of some progress in lung cancer. I gave a talk this morning. I edited a bit to get to some of the newer things that we're doing in the lab and share with you. I also see people from Jack Elias's lab here who, we miss Jack at Yale. It's been almost a decade now, but we've worked with him as well. So it worked in rehearsal. Okay, here are my disclosures. It's a little slow. So, lung cancer is the #1 cause of cancer death. It's not the most diagnosed cancer. Anyone know what the most diagnosed cancer is? I always do this at alumni events at Yale and give out a hat for people that get the. If you okay, he said skin cancer, so I'll give you the hat before I leave. But it's skin cancer, but it's a breast cancer in women because of screening, and prostate cancer in men. But we screen for lung cancer, and that's actually something that I would urge any cancer center to work on. We actually have to do better ourselves, but only about 5 to 8% nationally of patients who are eligible for screening get it. It's a little harder to screen for lung cancer because you do an X-ray, and then you find something, and then the biopsy is not quite as easy as a breast biopsy or a colonoscopy or a prostate cancer biopsy. However, lung cancer, when I started out as a fellow, when I was a fellow in Boston, this is what it was like. This is you can see, these curves are totally flat. In 1994, cisplatin, carboplatin was the standard of care for this disease. But really, let's see if the pointer works. I have to use this. The standard of care for this disease, but really the median survivals were quite low. The median survival here is less than a year. It's about 8 months. The 1-year survival only about 20–30%. So there needed to be some work done, and we were looking at new drugs, non-platinum combinations. But it was clear a paradigm shift was going to be needed, and that paradigm shift was science. And some of the students and postdocs asked me at lunch, why did I do lung cancer? And some of the fellows earlier today. At the time, that was a job that was available because no one really wanted to work in the field. It was pretty grim. But, think about pancreatic cancer now and some other tumors. Science can sort of change things, and that's what I want to show you through this talk. So the causes of lung cancer were always thought to be tobacco, and it is. 80% of lung cancer, you can find some tobacco exposure, whether it be smoking oneself or, secondhand smoke or maybe toxic substance like asbestos or radon or, polluted air. Charlie Swanton's doing a lot of work now to try to understand why there's so much lung cancer in Asia, and perhaps it's pollution. But then we know that in non-smokers, there are potentially actionable alterations, starting with EGFR, which is about 10% of patients in the US, about 30-40% in Asia, and then ALK and ROS1 and MET and ERB2, HER2, RET, NTRK, BRAF. All these are non-smoking related types of alterations. If one's a smoker, you tend to, get that first. But if you haven't smoked, these alterations will develop. Is there a genetic cause? That's often asked of me. We don't know of one yet. Matt Meyerson, at Farber, he's done massive studies, looking for some sort of something in the DNA, some sort of fragile site. It hasn't been determined yet. But, we think of lung cancer in two different groups, the non-smoking or light smoking lung cancer, and then the smoking lung cancer. And of course, smoking's involved in, I chaired a committee for the AACR for many years. We promoted, smoking cessation. If we did lung cancer screening and smoking cessation, we'd have as much impact, more impact than anything I'm going to tell you about today. But we're making progress in lung cancer, and these are the American Cancer Society curves. You can see on the top, you can see in men, lung cancer death rates sort of peaking around 1990, but now clearly that red line on top is on the way down. This is good news. Women, the peak came a little bit late because women started smoking once the tobacco companies promoted it for men. They then pushed the women, and the Virginia Slims, for example, and you can see that's coming down as well. You can see lung cancer incidence rates coming down both in men and women. That's probably somewhat due to prevention, primary prevention, but mortality rates coming down by even more. And these data, which are from a year or two ago, probably reflect mostly targeted therapy. I can't wait until we get the more updated results that show the effect of immunotherapy, which I think might even have a more durable effect.
The stomach cancer is interesting on that curve. It's continually going down from.
Right, and why is that, Wafik? Is that foods and diet probably, and better screening and
H. pylori.
H. pylori?
Treatment.
Yeah, that too.
Do you know why GFR happens more in women?
Well, no, and there have been projects looking at estrogen and other things, and it's not known. So I'm going to tell you about three things today: targeted therapy, immunotherapy, and some thoughts for the future. So targeted therapy. So, I got into this as a young attending at MD Anderson. Very fortunate. You talk about mentors, to work with John Mendelsohn, who was, of course, developing Erbitux anti-EGFR receptor antibody, and Wan Qihang, who was running the lung and head and neck group there. And I was very interested in gene transcription and regulation and growth factors from my PhD work. And I was offered to run some of the earliest trials with a drug called ZD1839, gefitinib, trade name Arissa. And we did some of these early studies where, patients with lung cancer, we don't call it this anymore. Now we call it adenocarcinoma with bronchoalveolar features, but we used to call it BAC, bronchoalveolar lung cancer back then. Every 1 out of 10, 1 out of 12 patients would have this amazing response. And at that time, it tended to be more common in women and Asians and people who have never smoked. I think it was more the never smoking in Asian than the women. But in either case, this was a phenomenon that changed the way we think of lung cancer. Someone comes in with this disease and they're on a great deal of oxygen, they're in a wheelchair, and they can, a week later they're walking out. It was uncanny, and the same thing is seen, by the way, if someone comes in with a spinal met and they can get up and walk again, or other debilitating symptoms. after probably 4 or 5 years and many patients being treated, this was early. Remember, this was in 1998, 1999. You were still sequencing. Anyone here ever run the old Maxim and Gilbert gels and Sanger? You know, it was before the really rapid automatic sequencing. But there was a thought that the tyrosine kinase, there might be mutations in the tyrosine kinase, and actually we tried to do some of this at MD Anderson, but we didn't have the capability. But up at Harvard and at Memorial, the Varmus group, Matt Meyerson and his group, Dan Haber and the group at Mass General, they actually, the drug became approved based on phase 2 data because of the responses, and then it was available in what's called extended access. You could get it almost everywhere. Get it for lung cancer. So responder, non-responders were sequenced, and lo and behold, this transmembrane receptor, external domain, transmembrane domain, and internal domain, specific mutations in the ATP binding site resulted in these drugs being super effective in addicted cancers. If you had a mutation here, the tumor was addicted to grow based on this EGFR. It was an automatic pilot. So and these small molecules fit very nicely into that site and turned it off. And it was really incredible. This is 2004. We just actually had a big symposium at Yale celebrating 20 years of that. I'll show you a picture at the end. So one of the first patients, this is like one of the first 10 patients we treated, Cicely over here. She was 9 years on gefitinib. And Tara Parker Pope, there was a lot of press about this back then, why curing your cancer may not be the best idea. The idea was that, I don't know that we cured anyone with metastatic disease because of resistance, and the drug works in a more static way than cytotoxic. But we did allow patients to live on drugs just like one might live on insulin, or one might live on antihypertensive and so forth. And this was the first generation of drugs. And again, just giving you a bit of an overview today, these were reversible inhibitors. Of course, EGFR, you know, we actually studied these drugs in colorectal cancer, breast cancer, prostate cancer, lung cancer, all epithelial type tumors. But the skin, skin was a big issue. Oftentimes, if you're doing the randomized trials, you would know who was getting the drugs because of skin toxicity and rash, also GI toxicity, and we're talking pretty bad toxicity, 7 or more loose stools a day. So the drugs have gotten more effective and less toxic over the years. There was a second generation of drug, which actually the idea was, let's be more effective if we target more of the HER2 axis, because it's HER1, 2, 3, 4, EGFR 1, 2, 3, 4 coming together 2 at a time, so 10 possible combinations. So some of these drugs were irreversible inhibitors, so longer half-life, obviously, because they were irreversible on the receptor. And these agents also targeted more receptors. They were also much more toxic. And then, about 8-9 years ago, we got osimertinib, which is EGFR mutant specific. So it only works on the mutant tyrosine kinase. So hopefully the skin and the GI tract are left out. That's not always true. As those who develop drugs here know, it's mostly specific for the mutant. But there's still some bleed over, and there's still some toxicities of GI and skin. The biggest concern is this interstitial lung disease, much more common in Asia than the US. We don't entirely understand that. But the one thing about these drugs is they were all developed to be more penetrable, to better penetrate the blood-brain barrier. So brain metastases, and if you talk to anyone, patient advocates that we have on our different review panels at Yale, and many patients I've cared for over the years, they're all worried about metastases, especially to the brain. So the fact that these do work in the brain to the point where you can sometimes take patients with small brain metastases and you can treat them initially with a drug and avoid radiation. What I just want to tell you about is that now these agents have moved up to the earliest stages of lung cancer. Lung cancer, most commonly diagnosed cancer, actually, it's found incidentally more than ever before, because anyone here, you have to be old enough, like me, have a calcium scan for the heart. The people have those. We've started reading those out completely by the thoracic radiology, because anytime you go into the chest, you can find a small nodule, an early nodule. Lung cancer screening, as I mentioned. Someone goes to the emergency room. How often does it happen? Someone just gets an X-ray and they have an incidental nodule. Hopefully you're told about it. But you can see stage 1, 2, and 3 disease, stage 1 disease, even the earliest lung cancer, a 3-centimeter nodule. no lymph nodes, either intraparenchymal or mediastinal here in the center of the chest. Still only a 60 to 70% 5-year survival. So there's room. This is why lung cancer screening is so important, but it's also been frustrating because we haven't had agents that we could give patients that could help as much as they could. Stage 2 disease, you almost never find stage 2 disease unless you've gone to surgery, because those are intraparenchymal lung nodules. Unless there's a hilar mass or something in the hilum, you don't usually see those with a scope or an X-ray. And then stage 3 disease. Stage 3 is probably the first lung cancer that was cured. Stage 3 is when you have mediastinal lymph nodes, or we call them N2 lymph nodes. My former mentors, Art Scare and Tom Fry at Dana-Farber, would say we can cure stage 3 with chemoradiation. We probably can, but still 20, 30%, and there are a lot of patients that could benefit. So the idea was these EGFR inhibitors, why not use these EGFR inhibitors in patients with earlier disease? And if you do that, maybe we can see a much more long-standing effect. We use chemotherapy, but chemotherapy, that was a good tweet. Chemotherapy only about 5%. So this is a trial called the ADORA trial. And I'm very proud of this because we started this trial, gosh, about 12 years ago. Even before osimertinib was fully approved, it was available. We knew that it was working in EGFR-resistant disease. But we all thought that the best, there was the idea that let's move these agents earlier. And we worked very closely with, collaborators in China, Yilong Wu, who runs the biggest hospital in China for lung cancer, and Masahari Suboi from the University of Tokyo. And we developed this trial, an adjuvant trial, because adjuvant trials take a long time because this is therapy after surgery. And, if the drug works, which you hope it does, it's going to take a while to have many events. And we're happy with that. We also built in a lot of translational work, as you'll see in a moment. We took patients who had EGFR mutation. The two most common mutations are in exons 19 and 21. Exon 19 is a deletion. Exon 21 is a point mutation. By the way, in metastatic setting, the deletion patients do better with the drug than the point mutation, and sort of makes sense. We were interested in brain, but this was an international study. It was run in hundreds of sites. So we didn't specify MRI. Sometimes people criticize us for that. We allowed MRI or a CT. Some places don't have access to an MRI, like that. It had to be an R0 resection, meaning that the tumor had to be resected completely, negative margins. Chemotherapy for adjuvant disease is it's a choice of a patient and a physician. So we let people choose. We didn't prescribe that. If someone had chemotherapy, they had 26 weeks, because chemotherapy is usually 3 or 4 rounds of 12 to 14 weeks. People had 26 weeks to start the osimertinib. If they did not have any chemotherapy, they had 10 weeks. Patients were randomized with 3 stratifications. There were 800 plus patients, so we had enough power for 3 stratifications by stage. 1B, 2, and 3A. There were about a third. The 2 different mutations were equally assorted in a stratification, because, as I told you, one does a little bit better than the other. And then race, Asian versus non-Asian. Just because there were so many patients in Asia, we wanted to sort of, in the non-Asian countries, we wanted to randomize. And then we gave either osimertinib at 80 milligrams once a day pill, either in the morning or the night, or a placebo. And there had been no studies that had shown targeted therapy to be used in the adjuvant setting in lung cancer. It had been felt to be too toxic. Metastases to the brain were always an issue. And there had been a few studies that had given 2 years of therapy with erlotinib, and actually that trial showed no survival benefit. And actually they messed up the control a little bit in that trial. So there was nothing prior to this. So this was ethically feasible and right to do. And then we treated for 3 years, and I'll be the first to admit that's a bit empirical. And I'll show you how we're using MRD, minimal residual disease, to try to better understand that. And the follow-up was, we have a 10 years follow-up built in. The trial was developed for a hazard ratio of 0.7, disease-free survival. You can do it 2 ways, by the investigator or by a randomized review. We decided to do it by investigator. In stage 2 and 3A patients, the 1 patients were felt to do so well. We saved that for a secondary analysis. So that's what I'm going to show you in a second. And then the secondary analysis was overall survival. It's a little bit more women than men. I don't think I included that slide, but it's totally pretty much equal. There were no main. For time, I didn't include that, but the demographics, there were no major differences between the two groups. But you can find that in that New England Journal paper on the bottom, or I can send it to you after. But very interestingly, the results in April 2020, the safety committee called us up, and it was a very, some of you I'm sure have been on these data monitoring safety committees. I do a few of those from time to time. And normally you close a trial because it's unsafe, you see a toxicity or you see futility. But I'd never gotten a call that the trial was looking too good, you have to stop it. So we were a little bit reluctant to do that at that time, because if you stop a trial for disease-free survival, you might lose your power to look at the overall survival, because patients ethically will then cross over, and we made sure that happened. But they convinced us that we needed to do it. We looked at the results, and this is what we saw. Really, again, expected this trial to be positive, but not at this extent. So this is adding in the 1Bs, remember half of those are cured just by the cutting of the knife. But here you can see patients who got osimertinib versus the placebo, and the hazard ratio is 0.2 or 80% improvement. So again, it exceeded expectations, which were already quite positive. I'm not going to show you too much about the toxicity, but it was, I'll show you one slide, but it was tolerable. We did a quality of life analysis, and it was in favor of the drug. Of course, you have more life, you have more quality of life. With time, this is after 3 more years of follow-up, you do see the curves sort of bananaing and coming together. So remember, the therapy stopped at 3 years. So there is clearly some patients who probably should have stayed on the drug longer, and I'll get to that in a moment. But a very positive result, and this was a plenary talk at the ASCO meeting that year, a virtual ASCO. And then, I told you about the brain. So brain metastases are clearly an issue, and osimertinib has greater penetration across the blood-brain barrier than any of the other tyrosine kinase inhibitors in class. So here we looked at brain progression, brain metastases, as the first sign of disease-free failure. And you can see the blue is patients who got the osimertinib, and the yellow is the control. And you can see the hazard ratio here is 0.24, or 76% decreased brain metastases. So, even without any survival data, this is 2020, the fact that the brain metastases are so much reduced. And I really fought, to get this curve analyzed. And we had April, and we presented it at the ASCO meeting plenary June 1st to get this analyzed, because I thought the brain data really made the case that this really is having an effect on patient outcome, even in the absence of a survival result. And people were very skeptical. Will you still see survival? There'll be crossover and so forth. Well, this was ASCO 2023 when we were back in person. And sure enough, there is a survival benefit. The blue is patients who got osimertinib. The yellow is the control at 5 years, 88 versus 78%. The hazard ratio, 0.49. And this is, Dr. Bertinoli would say that we want to have a 50% improvement in survival in all cancers. But at least in early stage EGFR mutant lung cancer, and it's a lot of work to do, we just made it more than 50% improvement in survival. And what's going to happen to these curves in the future? True cure would be like at 5 to 10 years. We've actually amended the protocol, and the sites are continuing to give us a survival update every year. So we're not going to look at it every year, but in 3 or 4 years, we'll do an update of this and see how patients have done, especially since many of them have come off drug. Of course, when they recur, what do? We can talk about that at the end.
All these patients had a similar mutation to start.
They all had either, they had an EGFR mutation. There were 2 mutations that were allowed in the trial, an exon 19 deletion or an exon 21 point mutation. Now you ask a good question, because there are many other mutations that one sees. Many of these, what we now call the exon 20 mutations, are right in between. Those don't respond very well to osimertinib. And then there are going to be other point mutations and so forth. I get calls about that all the time. What I do is, go to like my cancer genome or some of the online atlases. If you know that in the metastatic setting, these mutations have responded, I would say go ahead and use the drug. But for some of them, you need other inhibitors, some of the exon 20 drugs, which is a whole field of drug development to itself. But, this proves the concept, but only for the 2 most common EGFR mutations. Very nice question. Thank you. And this is just showing, people always ask about crossover. And you can see in the placebo group, 86% of patients on 88, sorry, on recurrence got an EGFR TKI, but only 43% got osimertinib. I wish that everyone could have gotten osimertinib. The trial was not written with a crossover to start because osimertinib was not even approved at the time the trial was started for use in the metastatic setting. That happened as the trial was ongoing. As soon as we got these results in 2000, we immediately revised the trial at all sites so that no matter where you were, all parts of the world, this trial was actually being done even in Ukraine. I met a few Ukrainian physicians today. It was being done all over the world. We made sure any place the trial was being done, people could get osimertinib. However, many had already progressed before then, and only 43% got osimertinib. So you could ask the question, if you had switched right at the time of recurrence, would the results be different? I would say the results so positive, probably not. And I didn't show it to you, but when osimertinib was compared to EGFR inhibitors, erlotinib and gefitinib, the hazard ratio is 0.8. So it's not that those other drugs are so inert. They're active EGFR inhibitors as well. And I'm very happy that 88% got some sort of EGFR inhibition. And now, in 2024, almost 2025, incredibly, it's certainly cold enough, I can feel the new year coming, that we now have all these other actionable mutations. And translationally now, we can think about, do we have to do another 800-patient trial? Absolutely not. There's already a smaller trial that was done with ALK, with alectinib, and it's called the ALINA trial, which shows the same thing, as well. And then I suspect that things like RET inhibition and NTRK and ROS1, they're equally as potent. So we're going to be moving to a world where we're going to want to know what the mutational status is before someone goes to surgery, because we're going to have all these drugs we can offer.
So one other question. So this is like there's so many mutations found in lung cancer. Did anyone map the sequential occurrence of these mutations? Like, it's not, some patient may have EGFR, some patient may have MET mutation c-MET. Is there anyone map the chronological kind of an evolution of this mutation, which mutation presents in a cancer patient first, or is it like a random?
Unfortunately, you tend to get one, and then you don't get others after you get that one. But then with time, under the pressure of selection for that one inhibition, you do start to see others. It's the type of thing that like the WIN consortium can study, right, Rafiq? We do need to have these data. What mutations come first? I don't think we know why someone gets EGFR, someone gets ROS, someone gets ALK. Someday we will, and then the resistance patterns you see are going to be different in the setting of selection pressure. So if in natural history, there probably won't be any resistance. As you use different drugs and at different times in treatment, you might see different mutations. And that's going to be critical because I've been doing this now since 1997. I've never seen anyone truly cured in the advanced setting. And in the early setting, maybe someone's cured. We don't know yet. So it's going to be very important to understand resistance mechanisms and then have the next personalized therapy. Very good question. Yeah.
So some colleagues of mine at Pittsburgh had identified in some of their cohorts large numbers of ATM.
That's right.
Would be an actionable target, let's say with an APR inhibitor or a PARP inhibitor or another thing. I don't see that on there. Is that something that just not really evaluated?
No, I'm going to show you in a moment where it's actually one of the projects on our spore. Where absolutely, and DNA repair is really essential to the whole process. So that's going to be the next wave. There are many people developing newer generations EGFR inhibitors, but I think we're going to have to look at what other pathways can be combined. I'll show you one slide on that in a second. Thanks for asking. So this is really the paradigm, and some of you might remember Josh Fidler. If you'd ever seen him lecture, you would not have forgotten him. But he ran the Metastasis Center at MD Anderson, so I had a lab with him for many years. I used to have a small lab to do some of my own translational studies, and the metastases cascade. The idea that many processes for a tumor to metastasize. If we could prevent metastasis, patients would live longer. So this is like a new paradigm, and I made this slide for the ASCO the year that we presented it the first time. we're using surgery, we're using chemotherapy, and that's all good. But now we're taking targeted therapy and preventing metastases to the liver, brain, and bone. So that's really, really very exciting. And the drug was, the osimertinib was approved in 2020 in the adjuvant setting. Now, minimal residual disease, this work's been submitted for publication. It's I just sent it back to the journal yesterday, but this was the presentation at ASCO this year. MRD. Now we wanted to collect. I said we collected plasma in all patients. It took 2 years to do a bake-off to figure out what test were we going to use translationally, because and then we also needed a test. We were working with academia, pharma community. We needed a test that could be done at large scale. So we ended up going with a study, a group called RADAR. I'll show you that in a moment. But the idea was that we had scans and we had ctDNA for these patients, and could that herald earlier recurrence? In fact, it did. We saw ctDNA with a median of 5 months earlier than we could see something on the X-ray. That doesn't always help unless you really know what the new mutation is, but it certainly allows you to make a treatment decision earlier. And certainly the main thing we wanted to ask was, should some people get treated longer? Maybe some people were being treated too long, and we could have stopped it. And these drugs are not without side effects. And you did see some patients with rash and diarrhea, and there's more side effects when you give something versus nothing. Remember, it was a placebo trial. So let me just show you a smattering of the results. Again, we use our RADAR. It comes out of one of Charlie Swanton's studies, but it's a tumor-informed assay. The question is tumor-informed versus not. Very hard to use a tumor informed assay when you're just seeing the person in a clinic. But when you've got all their tumor and you can do a whole exome sequencing on the tumor, basically make your own sort of assay, 20 or 30 mutations, and you make a tumor-specific cDNA panel. It's very time-consuming. It's very expensive, but we had some resources here and we had some time. So this is what we used in this study. And again, just to give you a hint of where this is going, we had ctDNA sampling initially every 12 weeks, and then we became a little bit more less frequent, after 3 years. But some patients had no MRD at baseline. That was actually most of them. These are all early stage patients, and we have tests which are probably not that sensitive. It doesn't mean you have nothing if we use MRD sometimes in the clinic. Negative result doesn't mean you're clean and all fine, but certainly a positive one does. And we did have a number that were detected at baseline. And then this is where we could look at clearance. And of course, those that got the active drug versus not, you can imagine, I don't think you have to, I'm sure you're all figuring that one out. And then MRD detected on study, which is, what do you do with that? And so these are the 3 groups. And let me just show you just something to sort of whet your appetite with this. So again, I didn't have the demographics for the whole set, but it's always good to show when you have a subset that your demographics between your treatment group and your placebo group look about the same as the overall group. It's pretty incredible to me that you do a study with all the resources in the world, big pharma, academic sites, leaders in all countries, and you still only get a quarter of the patients with plasma. In fact, that's pretty good, actually. Then I find out we've done the study with China, which had the longest accrual. They won't release samples from China, Then why do we collect them, But we are going to be able to analyze those someday if we do the analysis in China. So that's being worked on. And then many places, clinical research is not an exact science, and you either, I've run SWOG trials for years where we've asked for tissue and people send us just paraffin, and just look at the paraffin. But it's getting better. But translationally, this is why you want to really do quality control at your site as you send things out. Certainly, when you do your own studies translationally, I would recommend having someone in the there when you do the biopsies, just to ascertain, you get the tubes. These were all samples in Streck tubes, right? So then here's just two pieces of analysis. So here's the patients who had 18 patients had detected MRD at baseline. And that's not a good prognostic sign, obviously. But look, the blue are the patients who got osimertinib and the yellow are the placebo. So you're much better off getting the drug at this point, right? You can see the levels going down, and that's all good. Here's one patient that went up and down I looked at that, this patient went off for a toxicity. This one also went off for a toxicity. So it all sort of makes sense if you look at the case reports. But yeah, this is a little concerning, right? Here the drug stops at 3 years and see what starts to happen. Some of the patients become refractory, but certainly not getting anything doesn't help at all. And even if you're not curing these patients, you're getting progression, and metastases. And then here you can see there were 18 patients who started out positive. And the yellow is the control placebo and the blue is the treatment. So obviously, sort of showing the same thing here, just in a different way. You can see those patients on placebo, that's not good. But those patients who were on drug, who started out positive, they all turned negative. But then look, they're getting positive again when you stop. So this is why some patients might need a bit longer of therapy. And it's like personalized therapy. We're moving to a new era. And I don't think this paper is going to solve this problem, but it's going to open up a lot of discussion. And we're excited that hopefully it will get published before the end of the year.
MRD patients, again, is beautiful. Do they, I noticed you said it's based on a ctDNA, but do they also analyze the ctDNA for other mutation, or these patients are mostly look for EGFR?
No, EGFR is one of the, very good question, one of the abnormalities, but there are 25 other genes that they're looking at to increase sensitivity. That's why we do this so-called bespoke tumor-informed assay. Now, there wasn't enough sample there for me. I can't tell you whether the EGFR, I don't have data. Is it a different EGFR mutation? Has it changed? We don't have that.
Not for that, like, for example, if the patient do have an EGFR mutation, you're giving this drug, but if they are developing mutation in c-MET, now the one you were talking about earlier, precision to the precision, would you be able to now switch to this patient from c-MET or EGFR to c-MET inhibitor during the course of the
Right. So we don't get that from this assay because this is just taking the 20 or 25 abnormalities at baseline and using those to increase sensitivity of the test. But the first thing I would do in someone who became resistant, so let's look at it. Someone becomes resistant and they've been off drug. That's easy. I would say, look, make sure that they still have the EGFR mutation, make sure they don't have a resistance mutation, put them back on. But if someone becomes resistant on drug, you're not going to start to keep giving them the drug. Then, yes, you want to use the best test you have. Maybe there's a tissue site that you find. Do they have a c-MET? I know you're studying here. Jerry sent me an email this morning about the trials you're running. So I know you have a dual c-MET, EGFR, ADC. These are all things that one might try. Plus, I'm about to show you that, again, I just want to sort of, for this more research-based, I have a really good team, working on EGFR resistance. And, Mark Lemon's now our chair of pharmacology. Sarah Goldberg leads the lung program now at Yale. And Katie Paletti is my co-leader on the SPORE. So project 2 is EGFR resistance. So the types of things, again, I only have 50 minutes left, but the types of things we're doing is we're trying to understand, what are the mechanisms of EGFR resistance. And you can see a couple of those here. This is second-line osimertinib versus to first-line osimertinib in the second line. You're right, c-MET's a big part. It's still part when you use it first line, but there are other mutations as well. If you can find another mutation, that's always helpful. We actually, currently, we're looking at patients who have L858R mutations, which tend to do less well with osimertinib. And for those who have resistance, we're exploiting ADCs. So we're looking at HER2 ADCs. This might be a c-MET ADC. And then for those in a second aim, we're looking at synthetic lethal interactions with chromatin remodeling pathways, which I'm sure you're familiar with. So a couple of things. So one thing that Mark's lab has shown us very well is that different mutations have different sensitivity to different EGFR inhibitors. So again, the point of this is that differential sensitivity to, there are many different EGFR agents out there. So someday it might not just be, and John Haymack had a nice paper in Nature recently on this as well. It might be that and Jackie Robichaud, the type of mutation you have and the signaling there might specify which inhibitor one wants to use. The other thing that's quite interesting now is the whole idea of the SWI-SNF chromatin remodeling complexes and how they're involved in making tumors SMARC A2 dependent. And why is that important? Because if tumors are dependent on SMARCA2, there are inhibitors of some of those agents. These epigenetic modifications. And there's a company, I don't know if you can see it, called Foghorn that actually has an inhibitor there. So one of the things we're looking at is this as a mechanism of epigenetic regulation. So there can be new targets, there can be epigenetic regulation, and there can be new mutations. And finding out which of those three is important, that's the future. And then just to show you, someone had asked about mediators of CNS metastasis in lung cancer. I don't know if I included this today. Let me see if I did. I didn't, but Don is working on ATM inhibition and ATR inhibition using some of the AstraZeneca agents, and those came out of some screens as being evolved in brain metastases and in resistance to metastases. I think I cut for time. I'm sorry, but this just shows how osimertinib gets into the brain, and we have preclinical models here. One of the things we've done very successfully at Yale, and this is one of the areas that I lead through the dean's office, is we have a large alliance with AstraZeneca. They're located right in New Haven now. Alexion became AstraZeneca Rare Diseases. So we actually have 5 or 6 projects that mimic the projects we have on our NCI grants. So we get materials from the company and money. And as many of you know, the grants hardly can cover the cost of grants of research, especially in programmatic grants. So that's all I'm going to say about EGFR. I only have a few minutes left, but I did want to bring in a little bit of immunotherapy, but I'm going to skip some of the introduction because this is a very sophisticated audience. I'm just going to show you a few things that we're doing new in immunotherapy. I showed this morning. I'm overly ambitious. Okay, so I would say for immunotherapy, which works even better than targeted therapy, I've seen people cured with immunotherapy. I even have Vince DeVita admitting to me that we can cure lung cancer. For those who know Vince, he can cure lymphoma, but he's agreed with me we can cure lung cancer. But we got to do even better. So I showed this morning a patient who got immunotherapy who's cured 14 years later. That's about 10%, 12% of patients. We don't know in advance who's going to do well, who isn't. But now we need more targeted immunotherapy. And we need to understand, why is someone sensitive and why is someone resistant? That's going to be the goal. So we're very fortunate. We have a rebiopsy program at Yale. This was set up by Scott Gettinger and Katie Paletti, and we support it with some of our philanthropic resources and with the core from the SPORE. So anyone who's getting any targeted treatment, but we've now increased it to include immunotherapy treatment, we get a pre-treatment biopsy. We get tumor tissue, germline DNA. Then at response, we get another biopsy if we can, and then always at resistance, we get tumor tissue, and we also make PDX mice when we can. So the idea is we have tissue at sensitivity and resistance, and we've done that with immunotherapy. So many years ago, when Yale, I was very fortunate. I arrived at Yale about 14 years ago. Yale was already doing many of these trials. Mario Snow, I'm sure many of you know, Scott Gettinger, Harry Kluger. I was just very lucky to join them. We actually had samples, for one of our grant applications, 14 patients who are on a number of different immunotherapies in lung cancer who had response, that's the green, and then they had resistance, that's the yellow. So we had a pre and a post biopsy. So we started an immune sequencing group. At the time, we were working with Yossi Schlesinger and Rick Lifton as part of an alliance we had with Gilead, actually. And then we evolved that into an immune sequencing group and worked with Rick Lifton until he left for Rockefeller and continued to collaborate with his lab. So what we found is some very interesting results. So we actually found that, here's a patient who received immunotherapy and had a complete response and then recurred. So what we actually found is that we didn't see any actual changes in the new mutations. But what we did see is that beta-2 microglobulin, the patient lost both copies of beta-2 microglobulin in the resistant setting. So basically, the patient lost the ability to mount an adaptive immune response because they basically lost beta-2M, which is a critical component of MHC-1. And Kurt Schauper, who was our pathologist on this, went back to look at TCGA and then, of course, at large databases that we had from our Yale specimens. And this occurs about 5 to 10% of the time. So it doesn't matter how much immune checkpoint inhibition you give to these patients, you're going to have to look at more innate immune type mechanisms. So this is just something to think about as we think about resistance. And then we've been very focused on quantitative immune fluorescence. And I can't see it that well, but I've talked about the slide enough. I can tell you that we had 3 different groups. We have we looked at staining for CD3, so T cells. So this is low CD3, and these 2 groups are high CD3. And this group is high CD3, but with low granzyme and low Ki67, so suggesting that the immune cells are not active. And here's high. The third group is all the way on the right is high CD3 and high granzyme and high Ki67. And then we looked at survival and progression-free survival. And the green group, the middle group, group 2, does the best, which is actually was a little bit counterintuitive. Why would the group that had low granzyme and low Ki67 have the best outcome? And we've since working with Liping Shen, we've actually this paper came out a few years ago that there's a burned out subset, and this is work that was done using CyTOF of T cells in that group that has high CD3 but inactive cells, and we call them EBO, effector burned out cells. So these cells actually, in response to the PD-1 inhibition, all these samples were in patients who did not receive immunotherapy. Most likely, these specimens become they salvage. When you give the immune checkpoint, they become, or when you give chemotherapy, perhaps you kill out those cells and allow new immune cells to come. But this is just early data, but I'd suggest that this is the type of work we need to do, biopsies to understand the T cells, the microenvironment. And I'll just leave you with a few thoughts. So the way we think about immune resistance in our group is 4 types of tumors in lung cancer. And this is 450 samples that David Rim analyzed for us. And PD-L1 positive, TIL positive cells, and you can see the brown is the PD-L1, DAB, and the blue is the TIL. That we call that type 2. And in type 2 tumors, those are tumors that can either have a durable response, the patient who's cured. You can either have a partial response or response and then resistance. About 50% of patients respond to immune therapy and then become resistant or have stable disease, or you can have primary resistance. And this is a group which is very hard to study, but these are groups where probably we need to figure out what's going on there. But then you can see that there are 26% of the tumors, we call that type 3. And that's off target because there's plenty of TIL cells here, but there's no PD-L1. So these are tumors that probably have other checkpoints involved, and I'll show you an approach for that right now. And then we have many tumors that are cold. 45%, we call that type 1, and 12% type 4, where the PD-L1 is negative. Negative and the TIL is negative. These are those immune desert, those cold tumors that you need the bispecific antibodies, you need the tarlatinib, you need the CD3 T cell engagers, you need the T cell mimetics. This is a very exciting group to study. But I'll just show you a couple of examples how we target resistance in my last 5-7 minutes. So the first is, this is a project that Liping leads with myself, Scott, and David, where he actually looked at 6,500 membrane genes looking for homologs to PD-L1 and pulled out one protein, Siglec-15, a sialic glycan, lectin membrane protein, immunologic lectin protein. And actually, interestingly, this has now gone forward with an antibody to clinical trial. And this is a T cell activity assay. And what we found is, here's Siglec-15 and here's PD-L1. So PD-L1 and Siglec-15, see, they're similar in structure. Interestingly, interferon upregulates PD-L1 and downregulates Siglec-15. So if you have a cold tumor, interferon negative, those tumors tend to have a lot of Siglec-15. And we're still doing some mechanistic studies on this, not in the spore anymore, but we're funding it in other ways. But you can actually see that Siglec-15 is involved on macrophages, on tumor cells, as an immune suppressor. So everyone wants to study the next PD-1, PD-L1. We need to look at other checkpoints, and there are many more molecules like this. So just to show you how this works, this was a phase 1 trial that Pat LaRusso led, along with Tony Tolscher and Marty and the team in New Jersey. And you can see that in 14 lung cancer patients, one of them had a complete response, one of them had a partial response, a number had good stable disease. This was presented actually 4 years ago at National Harbor at the SITC meeting, and we're just writing it up now, unfortunately. So it's taken a while, but we just updated the data. But there's clearly activity, and what we chose tumors here that were PD-L1 low, and assuming that there's a reverse correlation with PD-L1 and cyclic 15. Now, David Rim is developing an assay for cyclic 15. But yeah, here's a response. Here's a patient who had immunotherapy with LAG-3 and PD-1 and did not respond. And then they got the cyclic 15 antibody. It's a company called NC318. And you can see a very nice response. So this is the next stage here, looking for other ways to target the immune system. And we have a team. So this was during the Charlie Fuchs era. So Charlie was our director. He brought Katie Couric up, because and she knows how to take a picture. So we even got this Pat LaRusso, just the most phenomenal phase 1 investigator. He even told Li Ping we were doing a picture, and he came and put on a tie. He almost never comes to the clinic. So phase 1 group, this is our phase 1 group. We'd love to work with your phase 1 group, by the way, in collaboration on trials. I know you have an amazing group here. So just to show you, so then for our next spore application, we had a homegrown drug because it came through a project on the lung spore, and they liked that at the NCI, and this scored the best on our application. But now we did a trial that Scott Gettinger and I led, where we looked at the drug alone, we looked at the drug plus a PD-1 inhibitor, pembrolizumab. We even plan to do an untreated group, a first-line group. These are both second-line. And this trial is just about completed, and we're actually seeing activity. So here's a patient who got NC318 pembrolizumab, refractory to IO, having a response. Another patient, refractory or response. Here's a monotherapy response. And here's another response. So we're seeing responses at about 15–20%. It's a small pharma. We're trying to decide how to take this forward. We're looking very carefully for a biomarker. And then in the last minute, I'm just going to tell you about something I'm really proud of, and that's the lung map. Because I know there's a lot of interest in the WIN consortium, and maybe they can collaborate with the lung map. So the lung map was an idea that started in 2012. Actually, there were two groups that were working on this. The NCI had a consortium meeting to talk about master protocols, Jim Dorshow and the team there. And actually, the real impetus behind this was my friend Ellen Siegel and Friends of Cancer Research. And the idea was, could we do a trial, a master protocol in lung cancer, and bring all the cooperative groups together, along with the NCI. Rick Pazder, sort of was pushing this from the FDA, and Harpreet Singh, although they have to be careful how they get involved in a clinical trial, but they advised us. And then the Friends of Cancer Research. And then I don't know if anyone's familiar with the foundation of the NIH. It's a very useful organization to pull together different stakeholders. So this trial, and here you can see the teams, it's team science at its very best. And one of the morals I like to leave today in the Calabresi tradition is bringing teams together. And I took a lot of lumps on this, pulling this together, but I shared this for 10 years. I just stepped down. And this was the idea. I talked to you a little bit about profiling, about immunotherapy resistance. Let's do bigger trials. Let's not do 20 patients at Yale and 30 patients at Brown and 40 patients at Harvard, but let's put them all into one screening protocol. And then for targeted therapies, we tested all these different targets. Sad to say, all of them are negative. So if we looked at BRAF inhibitors and BRAF had a little activity, but CMED, a few of these different agents, none of them really worked. But we also looked at immunotherapy, and we had sequencing and profiling on every patient that went on the trial. These trials are run at 600 or 700 sites around the country. There are more than 4,000 patients that have gone on. So it's a way to sort of have subarm protocols and to treat in specific ways and understand the biomarker resistance. And you can see these are all the sites that have been open. Many people joke this is a COVID map, but no, even during the COVID peak, we were still accruing because it's open in so many different places. So I just want to show you one thing. I'm about to end. So I was very fortunate. I was working on this trial of ramucirumab plus pembrolizumab. We have some preclinical data to suggest that VEGF inhibition increases T cell infiltration into tumor. It improves dendritic cell function. And we actually did a trial of ramucirumab, a VEGFR2 antibody, along with pembrolizumab, a PD-1 antibody. And the red are all PD-L1 negative patients with lung cancer, amazing response. And actually, this is in refractory lung cancer, IO naive. We had a response rate and a disease control rate of 85% and a response rate of 26% and an overall survival of 26 months. So it looked pretty good in phase 2. So we took this into the lung map, and we were able to accrue this trial in less than 2 years. Karen Redkamp was the PI in this study. This was presented at ASCO 2 years ago. The blue curve is pembrolizumab, ramucirumab, whereas the red is dealer's choice, docetaxel, gemcitabine, whatever you wanted to give in lung cancer. And the hazard ratio is 0.69. But it's about a 180 patient trial. It wasn't enough for approval. We wanted to do a big phase 3, and we got breakthrough designation, but the drug companies weren't interested in going forward. So what we did is we did what we call the pragmatic lung trial. And I just 2 more slides. The idea is SWOG 2302, a more simple trial. The FDA told us all we care about now is there a survival endpoint if you do a 700-800 patient trial? We will help you support this. It's a pared down trial. The only endpoint is survival. We're not even obtaining progression-free survival. It's real world, prospective, pragmatic data. The consent form, by the way, is only 6 pages long. You probably have it open here. So this is the pragmatic lung trial shown here. And this is our team. And actually, in less than a year, we accrued 700 patients. So the results will be available in about a year. But this is a nice way to do studies when you need to then confirm a result. You already know the toxicity of the combination. So I just wanted to show you the Pragmatica. So I've shown you a lot today. At Yale, my current work now is a personalized immunotherapy trial. We call it the iBulldog approach. So we're in the process of offering trials based on the immune phenotype. Stay tuned. I think we can cure metastatic lung cancer in some cases. At Yale, we have 14 years of experience of survivors. Treatment's well tolerated and retreatment is possible, but we don't know in advance who's going to benefit. So I would say, do we need to personalize immunotherapy? Absolutely. We've spent 20 years personalizing targeted therapy, and we're not even there yet. We better start being a little bit more biomarker focused, including more science with innovative trial designs and public-private partnerships. So the future of lung cancer is now, from early to late disease. I just want to show you this. So this is, we had our annual lung spore workshop at Yale this year, and we had 20-year anniversary of EGFR. Everyone we invited to speak or visit came. You can see Bruce Johnson in the front row, and there's Robert Wynn, John Minna, sort of the dean of lung cancer, Mark Chris. It was just an amazing event. It's online. We actually put the whole video in the cancer letter. There's Dave Carbone. But the idea is we're making progress. So thank you very much. Yes.
So thank you. Wonderful. See where we are today. Thank you. I have 2 questions. One is about the NUP1 trial. The WIN Consortium, Ray and Wapek is promoting. What do you think of NUP1 trial where every patient gets the right drug rather than having a placebo?
I love it, but I think it needs to be a basket, so you have to have more of that. So I think by doing a master protocol, 1 is probably not enough, but maybe you can get 10, 20 patients. The beauty of something like the lung map is, how are we going to do a study of 5%, PI3 kinase, or even NTRK, 1%? But if you have a big funnel and you bring patients with good performance status in, you'll get more patients on trial. The other thing about master protocols is, I didn't mention it, but it's one of my passions. It's diversity in clinical trials. It's access to clinical trials. You have to run trials at the point of care. You have to make it available to people. It'll increase the number of minority patients and others that can get on study.
So just one follow-up question. So you talked about immunotherapy. So a while ago, when I was at MD Anderson, Jim Allison and Pam Sharma, they were looking at PD-1, PD-L1, CTLA-4, and different immune checkpoint blockade therapy works differently, right? For example, CTLA-4 kind of helps in maturing the immune cells and recruiting them, and then PD-L1 works in exhaustion and in the other manner. So in your portfolio of your immune checkpoints, do you include early to late stage of immune checkpoint blockades, or is it predominantly the ones belong to the PD-L1 family?
Well, Jim Allison, CTLA-4 was his drug and the one that was used initially in melanoma. And you're right, it works more early in the priming in the lymph nodes, whereas the PD-L1 is more at the site of the tumor microenvironment. We actually, Mario Snow and Jed Walchuk did some beautiful work, looking at the combination in melanoma, and it's the case. We've looked at that in lung cancer as well. And it does appear that certain subsets of lung cancer patients benefit, those being low PD-L1 or no PD-L1, where you really need to prime and give a jump start. You want to be very selective in when you use the two, because the CTLA-4, it makes PD-1 look like a picnic, as far as the immune toxicities, a lot of colitis and a lot of pneumonitis and other side effects. But yes, I think, who is really PD-L1, that's the problem, because it could be a selection bias. But yes, we do often use those drugs, and there are several neoadjuvant trials that are ongoing right now. And I think that's going to tell us a lot, because then we'll really have biomarker pre and post and understand who would benefit, because there's a cost to that, but it might be necessary in those that really need some priming. Thank you.
Benny has a question.
Thank you for the talk, wonderful, and very interesting data on like 15 gradually are involved in a phase 1 trial for another antibody. I'm wondering if you can share any thoughts about the expression, the regulation in other tumor types. Is that also seem to be upregulated in other cold tumors, or is that primarily in lung cancer?
Well, we focused on lung, but I believe that if you look at Li Ping's Nature Medicine paper, I think they saw some upregulation also in colorectal cancer as well, and in some breast cancer patients. I know some of our breast group are talking with them about a study as well. I know the drug you're talking about, the Prixis drug, right? And they always call us to find out what's happening with these data, waiting for these to be published, because you won't find this anywhere. But no, I think it's a very interesting target. The problem is going to be, I would predict, like anything else, it's going to have a single agent response rate of between 10 and 20%. And while we all say we can develop a drug without a single agent response, that's very risky. So what will be the next step with it? But I think there's definitely proof of concept.
Other questions? Philip?
Can you make the comment on the BioNTech's messenger RNA vaccine combination? Are they targeting specific, let's say, EGFR mutation or combination of functional mutations for the vaccine?
I'm not so sure what BioNTech is doing. I know Moderna is working with Merck on a patient-specific vaccine. And the problem with vaccines, of course, it takes a while to sequence, make the vaccine. You need 6 to 8 weeks. So it's hard to sort of do that in the metastatic setting. But I know that there are some approaches now in the adjuvant setting. So there are some trials now where, patients might get neoadjuvant therapy, and then they, in the adjuvant setting, they might be adding in the vaccine. I think vaccines have a lot of promise. The problem is, how do you know you have the right neoantigens? It's a lot of in silico work and a lot of modeling. You have to find the right HLA and so forth. But yeah, I think vaccines are making a comeback, especially with the new mRNA approach, better sophisticated, bioinformatics. And then, of course, combining with a PD-1, PD-L1 checkpoint inhibition. We did trials in lung cancer for years with vaccines, and they had no chance of working, because what good is a vaccine if you still have the PD-1, PD-L1 blockade?
I have a question about resistance mechanisms. So, we use anti-EGFR inhibitors in colon cancer, and RAS is a well-known resistance mechanism. And I noticed that in the EGFR mutants, it was fairly low. And I was curious, how often does it coexist to start with? And, I suspect it's something having to do with small molecule versus antibody as to why it's not more common. But is there any information on combination with RAS inhibitors and EGFR inhibitors?
It's almost mutually exclusive to see an EGFR mutation and a KRAS. Part of it is, KRAS is almost always associated in lung cancer with smoking, the G12C being the most common in lung cancer, and the EGFR with lighter never smokers. I can only recall a couple of times, seeing the two together. So it's very rare.
What was in your slide with the
the resistance.
It was like 2 to 8%, something like that.
Yeah, I guess occasionally that can happen, but the problem is we don't really have.
There are a lot of people.
Good point. It's a couple of million. I think it's more like the 2%, but I hear you. Certainly, I think whenever someone becomes resistant, one, can you detect it early? But then, what is it? And then you have the right targeted agent. But the RAS inhibitors are getting better, right? We're moving on from the sotorasib and the adagrasib and so forth.
Rob,
Just a little follow-up on you mentioned briefly about the clinical trials for APM and other gene repair inhibitors. Love to interact with you guys if you need.
Sure, let's exchange information because, while we are accruing well at Yale, we're not the biggest site. We have only a few more analytic cases than you do.
Coming at it from a basic science perspective, but
you were supposed to meet him yesterday and you were
yeah,
late,
your train is
so.
late,
I can stay for 10 more minutes.